Late-onset sepsis in a preterm baby can turn catastrophic in under 2 hours. The whole thing in 3 minutes. This is the Mount Sinai Toronto consensus algorithm. The whole thing in 3 minutes.
The clock starts at the septic workup. Blood, urine, and CSF cultures, plus a baseline panel. Blood count, C-reactive protein, gas, lactate, glucose, sodium, creatinine. Antibiotics within 60 minutes. Try hard to get cultures first, but never let that delay the first dose.
From 1 hour out to 48, you watch closely. Blood pressure hourly for 6 hours, then every 2, then every 4. A targeted bedside assessment for signs of shock on a similar taper. Gas, lactate, glucose, CRP, and creatinine every 12 hours. Image if you need to. Progression to septic shock looks like this: hypotension, tachycardia, abnormal capillary refill, falling urine output, encephalopathy, worsening acidosis. Any of these, and you move into the shock arm. Fluids go in as 10 milliliter per kilo saline boluses, and you reassess after every one. Reach a minimum of 30 per kilo before starting vasopressors. If shock persists, you can go to 60 total and stop to exclude other causes, pericardial tamponade, for instance. Now, phenotype. Warm shock is a low systemic vascular resistance state. Warm limbs, flash refill, bounding pulses, hypotension. Cold shock is high resistance. Cool limbs, delayed refill, weak pulses, pressure that's low or normal. Here's what people get wrong. Most neonates with late-onset septic shock are warm. For warm shock, the vasopressor is norepinephrine. Start at 0.05 micrograms per kilo per minute. Titrate up by the same step every 10 minutes to a ceiling of 0.4. Target a mean pressure 3 to 5 above the 3rd centile for gestational age. If warm shock doesn't respond, consider hydrocortisone. Send a cortisol first if you can. Get an urgent targeted echo. Keep climbing the norepinephrine and add vasopressin if the echo shows no left ventricular dysfunction. Cold shock splits by blood pressure. Low pressure. Start epinephrine at 0.02 micrograms per kilo per minute. Ceiling 0.1. And get an urgent echo. Normal or high pressure. Use milrinone at 0.33. Target a falling lactate. Targeted echo earns its own slide. Get it in every case of hemodynamic compromise if it's available. Urgently for cold shock, vasopressor unresponsive warm shock, or severe hypoxic respiratory failure. Repeat it whenever the course changes unexpectedly. If stability still isn't there, management becomes individualized and echo-guided. Recognize early, phenotype fast, match the drug to the physiology. That's the algorithm.